Hello, everyone. My name is Professor Pauline Mackey. On behalf of the International Menopause Society, it's my great pleasure to welcome you to our webinar today. This webinar has been supported by an unrestricted educational grant from Bessens Healthcare. Bessens Healthcare had no role in the selection of topics or speakers and has not vetted or reviewed the content of the speaker presentations. Our webinar today is Brain Teasers, Challenges in the Cranium, and we have two esteemed speakers today, Professor Anne MacGregor, who will speak on menopause and migraine, and Dr. Riley Bove, who will speak on hormone therapy and multiple sclerosis, help or hindrance. I'll first begin by introducing Professor MacGregor. She is a specialist in headache and sexual and reproductive health care at the Center for Reproductive Medicine, St. Bartholomew's Hospital in London, and she has an academic post in neuroscience at Queen Mary, University of London. Her research and clinical work bridges neurology and reproductive health care, and she is an accredited specialist and trainer for the British Menopause Society. Professor MacGregor, welcome. We look forward to your presentation. I'd like to let the audience know that we will have the two presentations first, and then after the two presentations, we will entertain your questions. Please do put your questions in the Q&A. And without further ado, Professor MacGregor.
Thank you very much, Pauline. And I'm really, really impressed because you said migraine, not migraine. Perhaps we can have a discussion about which is correct later, but that's another story. So welcome, everybody. So I'm going to be talking about migraine as an often missed risk factor for the menopause. So let me just get my slides on to share. So hopefully everybody should be able to see those now. So just so that you can see my disclosures for advisory boards and speakers, none of which are actually relevant to our discussion today. So just to set the scene, I do work in a menopause clinic, and we looked at 117 women who were attending Bart's menopause clinic just before COVID hit us back in 2020. Median age was 51 years. And they had a consultation with the clinician, more often me, but also with some of my colleagues. And we got them to complete a diagnostic headache questionnaire. The prevalence of headache was significant. 62% of those women attending the menopause clinic were experiencing headache. And 42% of them had migraine, which is much higher than the expected general prevalence of migraine in the female population, which is roughly about 18%. So a greater burden in this population of women experiencing menopause. 78% of them with migraine were scoring very severe or substantial disability using the HIT6 score. Without going into detail, they were incredibly undertreated, even just at the level of symptomatic treatment. So huge burden. But despite all of that, women did not spontaneously, I can't say that word, spontaneously report headache as a menopause symptom. It was only when we asked them about it. What was really sad is this was a repeat of a very similar study that I'd undertaken in exactly the same menopause service 20 years earlier, and the outcome was exactly the same. Nothing had changed, despite the number of new medications, better recognition of migraine, and everything that you would expect to be associated with improvement within this population. Didn't happen. The other thing that we are aware is that migraine predicts more frequent vasomotor symptoms. So with some of the work that has been done by Malecki in the States, we can see that compared to a control population, particularly during late perimenopause, there's a significant increase of hot flashes and night sweats in women who are experiencing migraine compared to control population. So where does that leave us? It means that any of you dealing with women during the perimenopause need to ask about migraine. So anybody that you are seeing who is experiencing vasomotor symptoms, it is highly likely that those women are also experiencing an under-recognized burden of migraine. So let's just shift back and look at the effects of perimenopause on migraine. What do we know? So when we look at migraine prevalence and we look at it in comparison with estrogen levels, we actually see that the estrogen levels across a lifetime, so if you imagine that this graph is looking at the woman's lifetime, the estrogen levels are mirroring changes in migraine prevalence. So we see an increased migraine associated with estrogen fluctuations, particularly at puberty, where we see an increase in incidence of migraine in girls, and also again at perimenopause, where the prevalence of migraine starts to increase again with another sort of resurgence as women are approaching menopause. And at this time, we also see an increased prevalence of menstrual migraine. Now, when I talk about menstrual migraine, there is the International Classification of Headache Disorders that does define it, but essentially you can see it very simply by just getting women to chart out their menstrual cycle. So on these particular charts, menstruation is a circle for any particular day of the year, and the cross is a migraine attack. And the evidence supports that increased prevalence of migraine in association with menstruation is between the 2 days before the first day of menstruation and the 3rd day of bleeding. And if you see from these diaries, you can actually see that the diaries show that you can see this association irrespective of whether the woman has regular menstrual periods on the upper chart or whether menstruation is irregular, as often occurs during perimenopause or particularly late perimenopause. So easy to see this association just by the charts. Now, what is menstrual migraine? Why does it occur? Now, we're aware that menstrual migraine from a number of different studies that have been undertaken, one of which we worked on in the early 2000s. And we could see this very clear association if you look at the grey columns of increased percentage of days with reported migraine in association with menstruation. The menstruation peaking on the peak of headache days actually being on the 1st or 2nd day of menstruation. And this red column is highlighting these days of increased prevalence. So the peak of migraine is at the time of the lowest levels of estrogen following withdrawal of, or late luteal phase, withdrawal of estrogen. Now, why might that be happening more so in the perimenopause than during the previous reproductive years? Now, perimenopause for some women can actually be a hyperestrogen state. And if we consider the estrogen withdrawal mechanism for migraine, we can see that during the mid-reproductive women, there is both a lower mid-luteal height of estrogen and a lower rate of drop as well. When we compare that with the perimenopausal woman, we see that the mid-luteal phase serum levels of estrogen can be much higher, and therefore that leads to a greater rate of change as it drops down to menstruation. So that might perhaps account for why menstrual migraine becomes more prevalent in perimenopausal women. We also see on the right-hand side, if we look at progesterone levels, we see that during perimenopause, some women are not achieving that same attenuation from progesterone acting to attenuate estrogen as they were doing so during their reproductive or earlier reproductive years as well. So all of this can lead to an increase in migraine prevalence at this time. Now, I'm not going to go through all this in detail, but this slide is really just to show how estrogen is a brain hormone that can actually lead to increased migraine. So we know that estrogens enhance neuronal excitability. We know that they upregulate the another word I can't say, synthesis of CGRP, that's calcitonin gene-related peptide, which we know is a significant factor in the process of a migraine attack, and its subsequent release, which enhances vasodilation. We also know that estrogens enhance the production of NO that's involved in migraine, and other aspects on GABAergic, noradrenergic, and serotonergic systems, again, that have all been implicated in migraine. So estrogen is very much a migraine precipitating hormone, all leading to increased migraine attacks. So if we then move to considering what happens with menopause and migraine, well, it's not surprising to be aware that improvement in migraine occurs with increasing time post-menopause, mirroring the decline in ovarian activity. So if we look at a study of over 1,000 or nearly 1,500 women at various stages of menopause, and we're shifting from pre-menopause on the left-hand side through to natural spontaneous menopause in the penultimate column, we see this increase in the prevalence of migraine associated with the different stages of perimenopause compared to premenopause, and the reduction in prevalence of migraine post-menopause. The final column actually shows you how surgical menopause is associated with an increase in the prevalence of migraine. And that is independent of whether there is unilateral removal of one ovary, both ovaries, or indeed just a hysterectomy. So menopause, surgical menopause is not a good treatment for migraine. And you can actually see how natural menopause here protects with an odds ratio of 0.6. Confidence intervals are under 1 compared to the surgical menopause, where nearly a 2-fold risk and the confidence levels are above 1. So these are statistically significant outcomes. So what about HRT? So with HRT, we have no data in perimenopausal women with migraine. We have no data at all of the effects of HRT. So if we look at postmenopausal migraine, we do have some data of the effect of HRT, and it's not good. Across the board, all the studies show that HRT is associated with an increased risk of migraine. So these data from the Women's Health Study in over 17,000 postmenopausal women showed that current users, the odds ratio was 1.42, and it didn't really make much difference as to whether they were using estrogen only or whether they were using a combined estrogen-progestogen form of HRT. Similarly, in Norway, looking at 5,500 postmenopausal current or ever users of HRT, very similar outcomes, that the risk of migraine increases in those who are using HRT, irrespective of the combination of HRT, estrogen only or combined. Now, if we then consider about the type of estrogen. So within those regimes, there wasn't really significant amount of data on what type of estrogen they were using, whether it was patches or tablets. And part of that is because when those studies were undertaken, the majority of HRT used was actually oral, majority being the equine estrogens. So although there are some data we could tease out, we don't really have really good comparative data. So in this particular study of postmenopausal women, we're down to only 30 women who were followed for 6 months, who were treated with the same cyclical regime of either 50 microgram patches with 10 milligrams medroxyprogesterone acetate cyclically, or continuous combined equine estrogens with cyclical MPA, as in the previous group. So continuous estrogen, cyclical MPA, estrogen patches versus oral estrogen. Now, if we look at the effect of this, you can see with both frequency of migraine, the oral is the dashed line and the patches are the solid line. It would appear that oral estrogen is associated with an increased frequency of attacks and increased days with headache, whereas the transdermal, over time, there is no change. So in both groups, there appeared to be an initial increase, but by the 6 months, it was only those who were using the oral estrogen that were still experiencing more troublesome problems with their migraine, whereas there is very little change with the transdermal patch. But be aware, we're talking about very small numbers of patients in comparison to the number of people who are using HRT. So let's have a look at what's happening with progestogens. We've got 38 women in this particular study. So again, this just shows how under-investigated migraine is, which is very surprising considering the burden of migraine that women are experiencing. And this was a 6-month parallel study following 38 women after a 1-month baseline. And this was looking at different progestogen regimes. So they were all using oral estrogens, even though they were slightly different types. So it could be estradiol or conjugated equine estrogens. But the regimes were really differing between a continuous combined, a cyclical combined, so continuous conjugated equine estrogens with cyclical medroxyprogesterone acetate. And then the third arm, which was not really an arm that any of us would use anymore, was looking at cyclical estrogens for 21 days and a cyclical cyproterone acetate, the progestogen, for 10 out of the 28 days. So it's really only the first 2 groups that more perhaps reflect the way that we might prescribe HRT nowadays. So all of the regimes were associated with an increase in attack frequency, as we would expect from the previous data looking at HRT, increased days with headache and analgesic consumption. But if we looked at the continuous combined, so that was using estrogen and progestogen daily, this was the best tolerated regime of those that were studied in this particular group. So small populations, but they are perhaps giving us a little bit of insight into how we should be approaching the management of these women. What about the type of progestogen? Does that make a difference? Unfortunately, we have 0 data about that. So we can't make a judgment. We have to work through from basic first principles. So let's just recap where we are with that quick whiz through about the limited data that we have about migraine and menopause. So we know that estrogen is a neuroexcitatory hormone. We know that perimenopause for some women can be a hyperestrogen state, and that can be associated with an increased risk of migraine and an increased risk of menstrual migraine for reasons I have explained. We know that migraine is associated with an increased risk of vasomotor symptoms, which mean these women are going to need to be treated if those symptoms are severe. So HRT may well be a strategy that we are needing to look at for management. If we look at the data about HRT during perimenopause, we have no data. If we look at the data about HRT during postmenopause, all of the data appears to point to an increased risk of migraine. So not very good for our poor women who are trying to manage their migraine. So let me move on to the second half of my presentation, which is really trying to help you come up with some practical recommendations about how to manage pre or perimenopause and postmenopausal women with migraine. The first thing to say is signpost women with migraine to their family doctor or to headache services for management of the symptoms of their migraine attack, and if necessary, consideration of standard migraine prophylaxis. That's the most important thing to do. In perimenopausal migraine, there is the opportunity to consider managing this hormonal migraine trigger. So what's the best way of doing that? Probably the best way, we've got this hyperestrogen state. We don't want to add HRT to it because HRT is just going to add on to the background of the endogenous hormones. So the best management strategy is actually going to be to put those ovaries to sleep and replace the hormones with natural estrogen where possible. I'll discuss that in a minute, using combined hormonal contraception. That's going to give us the best management strategy. And this paper that I've placed on the right-hand side here just looks at the consensus statement of the European Headache Federation and European Society of Contraception and Reproductive Health with respect to use of endogenous estrogen and progestogen. These are contraceptive hormones. We weren't looking at HRT in this particular paper. And the consensus with weak evidence does suggest that there is the opportunity to use combined hormonal contraceptives in this particular population. The reason behind it is that continuous combined, so extended regimes without estrogen withdrawal, without the hormone-free break, can benefit menstrual migraine. It's suppressing ovarian activity, so it's suppressing this hyperestrogen state that we're seeing in this population. It can also effectively treat vasomotor symptoms, also has the advantage of managing menstrual disorders, and provides contraception in a population who are often needing contraception, but often get missed out, believing that they're possibly infertile and yet they can still become pregnant. The problem, obviously, with hormonal contraceptives and migraine is that migraine with aura, the presence of aura, is associated with increased risk of ischemic stroke. It's not causal. Migraine aura is a marker of an individual who has risk factors for ischemic stroke. But we do need to be more cautious, certainly within the UK, Faculty of Sexual and Reproductive Healthcare contraindicates use of combined hormonal contraceptives, but notably for contraceptive use. So there is some leeway if we are using contraception for a medical indication. You need to balance the benefits versus the risks. The effect of combined oral contraceptives on hemostasis and this risk of thrombosis is mainly driven by the ethinyl estradiol component, the synthetic estrogen. And we now, certainly in the UK, have the availability of two combined hormonal contraceptives that contain natural estrogens, whether it's estradiol or whether it is E4 estetrol. And these appear to have less impact on hemostatic parameters. So maybe with further data, we may be able to consider healthy women using them up to age 55, and perhaps there would be less caution with migraine aura if there is less effect on these hemostatic parameters. So finally, looking at postmenopausal women, again, we need to signpost women with migraine to their family doctor or headache services. And we need to consider how best to mitigate the adverse effect of HRT on migraine. So we can't clearly use HRT as a beneficial treatment for migraine. We are mitigating the adverse effect that it is going to have. So it makes common sense to minimize hormone fluctuations, ideally using a continuous progestogen, and probably transdermal estrogen, since that appears to be associated with minimal fluctuations. We have to be careful not to push the dose up too high in a migraine population, because high estrogen levels we know can also in themselves trigger migraine aura. We see the evidence in women starting combined hormonal contraceptives for the first time. We see it in pregnancy. We see it with oral HRT. So practical recommendations for migraine aura, it's not a contraindication to HRT because we're using physiological doses of physiological hormones. We do want to use the lowest effective dose of estrogen to control the vasomotor symptoms. And if migraine aura increases in frequency, we need to consider non-hormonal options. The ones that can be used that have been shown to also help migraine are SSRIs, escitalopram and paroxetine, the SNRI venlafaxine, and the alpha adrenergic agonist clonidine. But they do all have other unwanted effects as well, and some limitations. So we do need to counsel women regarding those, and obviously they lack some of the other specific benefits associated with HRT. In all women, we should also be looking at lifestyle factors, so exercise, weight loss, and there are also benefits of cognitive behavioral therapy on both migraine and vasomotor symptoms. So thank you very much for your attention with that. I have put up a couple of papers that you might find of interest with further reading, and at a later point, I'd be happy to answer any questions. I'll hand back now to Pauline.
Thank you so much for that enlightening presentation, Professor MacGregor. We will wait to take questions for Professor MacGregor until Dr. Bove has made her presentation. Dr. Riley Bove is Associate Professor of Neurology at the University of California at San Francisco, where she is founding director of the Sex and Gender Enriched Neurology Program. A specialist in multiple sclerosis, she received her undergraduate degree in biological anthropology at Harvard College, followed by a Master's of Science and a Medical Master's of Science degree from Harvard Medical School. On faculty at the University of California at San Francisco since 2015, her research focuses on sex and gender-related aspects of multiple sclerosis, particularly the menopause transition. So Dr. Bove, welcome. We look forward to your presentation. Just a reminder to the audience, as you come up with questions, please do put them in the Q&A. Thank you.
Well, thank you so much for the kind invitation. And thank you so much, Professor MacGregor, for the wonderful talk. So I'll just sort of preface this with sort of, I'm a neurologist in menopause land. So please forgive any cross silo differences or lack of knowledge, but I'm really excited to talk to you about how we've tried to bring menopause research into multiple sclerosis. So and specifically focusing on how difficult it is to study hormone therapy. Here are my disclosures. So just an overview of the talk. I'd like to just have a very brief overview of multiple sclerosis, and then talk about what we know about MS and menopause with respect to the age at menopause, what happens during the menopausal transition, the perimenopause, and then why is it so challenging to understand what happens postmenopausally and how to treat it. And so here is just a brief schematic of sort of a normal neuron in the central nervous system. And what happens with multiple sclerosis is you have demyelinating injury where the immune system attacks the myelin sheath. And then secondarily, you have loss of sort of axonal integrity and neurodegeneration. And so there are two separate processes happening in multiple sclerosis. And in either demyelination or secondary neurodegeneration, leads also to changes in electrical conduction and sort of the symptoms that are experienced by individuals. The pathophysiology of MS is very complicated, and I just show this to talk about when we're thinking about what happens to the central nervous system as a consequence of MS, we have to think not only about the immune cells in the peripheral system and the peripheral vasculature, but also the many types of cells that that are sort of involved in the brain, not only the neuron, but also all the protective cells as well, the oligodendrocytes, which create the myelin, and so forth. And so it is a complicated picture to understand what happens to human beings in vivo. And so when we think about the symptoms of multiple sclerosis, really that hallmark loss of ambulation is just really the tip of the iceberg. There are so many ways in which dysfunction in the central nervous system is experienced by individuals with multiple sclerosis. And in bold are the ones that are sort of visible, in non-bolded are the ones that are quite invisible to the naked eye or to the neurologist's eye. And purple are really the ones that can really overlap with sort of what is experienced during the menopausal transition. And so just to show again the sort of complex picture that we're facing, and to sort of reproduce the stages of reproductive aging, MS typically starts in women, 3:1 females to males in the reproductive years, sort of peak onset in the 20s, 30s. But the individuals living with multiple sclerosis, the median age is really in the early 50s. And so half of individuals with multiple sclerosis, half of women with living with multiple sclerosis are actually postmenopausal. So just sort of thinking about those differences between incidence and prevalence as it relates to MS and this menopausal transition. This is sort of the classic depiction of the phases of multiple sclerosis, where you have accumulating injury and clinical disability, accumulating disease burden, and then sort of worsening brain volumes over time. And historically, relapses have kind of tended to end and progression has tended to start right around the age of 45 or 50, right in the middle of that sort of perimenopausal transition. And so this is a really epidemiologically interesting question for all these reasons. And what we're seeing more and more is that individuals with MS who've been diagnosed in the last 20 years are approaching menopause in much better physical condition, with much lower rates of disability and with very legitimate questions about what happens next and how they should be treated. And so we're sort of really sort of facing a big shift in sort of the questions also from patients about what they should experience and what we should do. So when we started looking at this, we really just, there's very, very, very little known sort of objectively about any of this or qualitatively about any of this. And so we started with some basic questions, which was, is the age of natural menopause in women with MS different from the age of natural menopause in the general population? And that's relevant because women with epilepsy, for instance, as a result of either the underlying neurological condition or the medications they've been exposed to, can have earlier age at natural menopause. And what we saw in 2 studies and was also observed in a 3rd study was that the age of natural menopause, the median age, is really quite in line with what's expected in the broader societal context in which patients are living. There are some patients who've had sort of earlier iatrogenic menopause due to earlier treatments that are not used so much anymore. And so then we thought, well, okay, so what is the experience? Just what are we going to look at here? Because we just, we're starting with a bit of a blank slate. And so we asked patients on an online forum, patients like me, what about their menopause and their multiple sclerosis? And it generated a lot of different qualitative lines of research that we've then been able to follow up upon. So some patients talked about the perimenopausal onset of MS. So 10% of people present with multiple sclerosis age 50 or above. But many talked about this overlap of MS, menopausal, and life changes. And just to kind of try to disentangle for you everything that's going on for an individual with MS, they have sort of normal, healthy aging. They have the menopausal transition, and then they also have all of the symptoms that are affected by MS. And sort of right in the middle are things like mood, sexual function, sleep, fatigue, and bladder symptoms, as well as the heat sensitivity that's a hallmark of multiple sclerosis, where symptoms are transiently worse in heat. They were talking about being really bothered by the hot flashes. How did this play out a little bit? We just published a study looking at sleep, mood, and quality of life in menopausal women with MS who were experiencing vasomotor symptoms. And we really tried to sort of disentangle what is experienced during this perimenopausal transition, and then what are we talking about when we think about postmenopausal changes. And so really honing on the perimenopausal transition, this is sort of a very difficult to read figure, basically, so I'm very sorry in advance. But what we were able to show is that there were significant correlations between sleep quality, so PSQI, as well as vasomotor symptoms, as well as general mood, and sort of overall mental health, sort of emotional, cognitive, self-reported quality of life in these individuals with multiple sclerosis. And in fact, in the clinic, that when patients present, it really feels like they're falling off a cliff at the menopausal transition, because all of these things that I've shown you here sort of are kind of really just exacerbating at the same time. And so a key component of sort of clinical management is anticipatory guidance, that they may experience many symptoms that were really kept in check in their 40s and sort of in their sort of late reproductive years. They may really experience a sort of a recurrence of all of these symptoms, and they may really flare during the transition. And so providing them with that anticipatory guidance can really help warn them about what's to come, and also all of the options that we have to mitigate the symptoms. So when we think about menopausal hormone therapy for the sort of for the menopausal transition itself, so how do we treat these patients who feel like they're just getting so much worse with the vasomotor symptoms and so forth? I just want to show you the two RCTs that have been done, or actually the two interventional trials that have been done. And I just want to point out to you why this research is so difficult. We've come to this question sort of at the end of the Women's Health Initiative, where there's very, very low rates of systemic hormone use, hormone therapy use, at least in the United States, less than 20% in a lot of our clinical cohorts. And so the interventional trials, there's sort of a burden of acceptance of even participating in interventional trials. And so I'm showing you sort of the process where we sort of tried to recruit patients in a single center trial. And, so many patients were not interested in the study because of concerns about risks of systemic exogenous hormones. And so it becomes difficult to sort of recruit sort of a population and to do these studies in a time-efficient way. I think that's changing now. This study we started about 8 years ago. It is changing a little bit. And then, of course, we know that there are strong placebo effects, and you really need high numbers to sort of overcome these, and also overcome the noise of multiple sclerosis, given how sort of multidimensional it is. And so, it's very difficult to say anything about the actual efficacy of the medication. Here's the other trial that was done. This was a trial done by a different group. And what you can see, two things, again, very, very low N, only 14 individuals with multiple sclerosis, and there was no placebo or sort of, comparator group. And so this study looked at depression, BDI, and they showed significant improvements in mood in both the people with MS and the healthy controls who were exposed to this regimen of treatment for 1 year. Given that we have such little interventional data and also such little observational data, given sort of the low rates of use in our populations, I just want to sort of go back to sort of the perceived benefits and risks of systemic exogenous hormones in general for menopausal therapy, for menopausal treatment, and just really emphasize that besides the effect on clotting risk, there really are no sort of MS-related reasons why we should differ from sort of what's known for the general population. Meaning, if we have patients with multiple sclerosis who are experiencing menopausal symptoms during the menopausal transition, they should be treated according to standard of care. And I think that's something that we're really trying to just hone in on. And yes, some of our patients will be more sedentary, and then we worry about the clotting risk. But besides that, the patients deserve some form of treatment. And as Professor MacGregor just really nicely showed, you can also consider non-hormonal treatments if the hormonal treatments are not indicated. So what about what happens after the menopausal transition? What happens in the postmenopausal period and with respect to women with multiple sclerosis? And we got sort of a mix of sort of reports from the patients that we asked initially. Some felt that their MS really progressed significantly postmenopausally, and some really were not sure at all. These are direct quotes. So here's some challenges in the study of sort of what happens to MS in the postmenopausal period. So animal models don't fully account for the long duration of postmenopausal longevity in humans. Postmenopausal longevity is an adaptation in the human species and in several other species. And so if the animal models that are used don't quite have that same evolutionary adaptation to this, the brain changes may be actually different. They may not have the same compensatory mechanisms for loss of gonadal hormones. There's been an almost exclusive emphasis on estrogen in neurological patients without really thinking about the other hormones that change, as was so nicely shown with progestogen, or as well as androgens that are also produced by the ovaries. When we think about the decline in ovarian hormones, could the effects that we see be linked to loss of direct neuroprotective effects? Could they be due to accelerated mechanisms of general aging? Again, sort of endothelial function or energy metabolism or such. Could they just be correlated, sort of true, and not necessarily causal? And could worsening in function that results from chronological aging or menopause be misinterpreted as worsening in neurological function? And this is really important because our disease severity scale is a very coarse scale in MS, the EDSS, and there's actually a lot of non-MS that gets jumbled in with sort of the way that we rate neurological disability progression. This is a cleaner study that was done in the general population, showing an effect of surgical menopause on cognitive aging and neuropathology long after the menopausal transition. So this was a study that enrolled women in their 70s and followed them longitudinally. And what we could see is that the people who had early surgical menopause entered the study with lower cognitive function and worsened more significantly over time. So in MS, again, I've explained why it's a little harder, it's a little less clean, because there's a lot of complex pathology, there's a lot of complex neurology. The animal models are imperfect, and then again, also there's been bias in terms of not considering this an important topic of research for a long time, and I think that's really important to note as well. There haven't been a lot of research dollars put into the story. What we have found in two groups, and one other group was also showed, is that there does seem to be a slight worsening in disease severity postmenopausally. It's not clinically very significant. Statistically, it does appear to be significant, but this wasn't observed in all studies, and in fact, two did not find this at all. And so the effect may be modest, and it may depend on what markers you use. This is a more recent study that we presented at the AAN this year that showed that when we used a more objective functional composite, or when we use neurofilament light chain, the serum biomarker of sort of neuronal degradation, neuronal injury, we did see a slight worsening in the rate of worsening after the final menstrual period. So what about hormonal therapy for progression of multiple sclerosis, not for the menopausal symptoms, but to prevent this progression? There are few interventional trial data in MS. So of course, in the non-MS populations, we're starting to see a possible benefits of systemic estrogens on cognition or MRI outcomes, possible protective effects. In MS populations, again, there are no trials data in menopausal women. There are some trials data in cycling women that suggest a modest effect on inflammatory activity or cognition or NFL. But then again, this is women of childbearing age. This is not the menopausal population, and this is not the postmenopausal group specifically. There are some confounded observational studies. Again, they're very, very low rates of systemic of exogenous hormone use. And in the historical cohorts where there was greater use of systemic estrogens and hormones, there were large biases. So this is a study that we did with the Nurses' Health Study. We found that at the menopausal transition and sort of postmenopausally, women who use systemic hormone therapy were in better self-reported physical function, had better scores. But that said, those people had better scores even before the menopausal transition. So the women who went on to use systemic hormones were the ones who were doing better before menopause. And that suggests that it's really the people who were doing better, who were less susceptible to sort of clinical and diagnostic neglect, and who were likely to get the age appropriate treatments, including hormone therapy at that time. So we have put together some best practices for management of postmenopausal women with multiple sclerosis, and not to get too far into the weeds, but really thinking about increasing visit frequency and anticipatory guidance, and really symptomatic management for people who are experiencing these exacerbations and fluctuations during sort of the perimenopause, and then really focusing on how do we set patients up for healthy aging for the many decades that they'll live beyond the menopausal transition. I just want to note two other things. One is that, the pivotal trials that we have to guide MS therapy use in our patient population, we did a systematic review of 29 of those a few years back, and found that only one included patients age 55 or above. And so we don't have data on safety, efficacy of medications in our postmenopausal patients. And this is just critical, so real world data can bridge some of the gap. And then I also want to show you just one other story, which is a story of just being really mindful of mechanisms. This was a study that we were running. I was really interested in whether SERM, selective estrogen receptor modulators, could promote myelin repair, going back to some of those mechanisms that I showed you. And we were able to show that selective estrogen receptor modulators in an unbiased preclinical micropillar array, SERMs were able to promote oligodendrocyte, a precursor cell, differentiation, proliferation, and wrapping of myelin around little fake axons. And we saw that they were also, that this beta-doxyphene, which is one of the SERMs, was able to promote myelin repair, so sort of remyelination with the beta-doxyphene after demyelinating injury. And so, at that point, I thought, well, this is fantastic. Estrogens work, SERMs work. We're doing, we can promote myelin repair. Wonderful, wonderful. And then my collaborator, Jonah Chan, said, well, we really have to look at ER knockout models to prove what the target is. And what we found, which was kind of remarkable, is that the SERM promoted myelin repair even in ER double knockout animals, suggesting that the remyelinating effects of the SERM were, even though the SERM does act on estrogen receptors, that the remyelinating effects were independent of the estrogen receptors. And in fact, we were then able to do some other analyses that suggested different targets. And so the moral of that story is that it's very complicated, and we have to really get to the mechanisms, or else we, can risk sort of misinterpreting sort of what we're finding in our research. This is just the trial design of a trial that we have now, looking at one of these selective estrogen receptor modulators, beta-doxyphene, as a potential remyelinating agent in humans. Again, there are many, many obstacles to doing this research, and we're about 2/3 of the way recruited. So hopefully we'll have some data on some SERMs and myelin repair in the years to come. So just to summarize, menopause is a common time for worsening symptoms, and it's often really multifactorial. Really a proactive approach is recommended, and hormonal therapy can help with vasomotor symptoms and other symptoms in our MS patients, because it helps in the general population, of course, and just sort of bearing in mind the very few MS-related contraindications. And then there's possible mild increase in the rate of disease progression after menopause, but we just don't have the data to suggest whether or not menopausal hormonal therapy helps with this. And so I just want to thank you all, and thank the organizers, and thank my lab and collaborators.
Thank you so much, Dr. Bove, for that enlightening presentation. We don't hear often about multiple sclerosis, so I'm sure that was a topic of considerable interest to our audience. Let's move on now to the Q&A. A reminder to our audience, please type your questions into the Q&A underneath at the bottom of your screen, and let's dive right into the questions. So, Professor MacGregor, what do we know about testosterone and migraine?
Caught you out on that one. It's a really, really difficult area, this one. The only data that we have about testosterone and migraine relate to 3 studies that have looked at the use of testosterone implants on women with migraine. The first one was published in 1955, the second one was published in 1974, and then a more recent one was published in 2012. And they're within each of those studies, there are challenges that make it difficult to interpret how relevant that would be to a usual population of women being treated. But the evidence really isn't out there to show that testosterone, certainly in the forms that we usually give it, transdermal testosterone, there are no data.
Okay, thank you. And Dr. Bove, you mentioned that beta-doxyphene has effects on myelination, and we know that hormone therapy has effects both on degeneration and on inflammation. Which of those mechanisms of action do you think are particularly important to consider in the context of MS?
I think it's a great question. I think it depends on the time. So the inflammatory activity is much more sort of pronounced in 20s, 30s, 40s. And so during that time, the effects on sort of visible inflammation are particularly relevant. I think in the postmenopausal population, we do, in males and females, we do see a decrease in inflammatory activity overall. And so I think that the 2 subtleties are, this is an overt inflammatory activity. We don't really see the inflammatory activity that's happening, sort of the innate immunity that's sort of happening that we don't visibly see on MRIs, and it's happening in the normal appearing white matter. And I think that's something that we just don't know enough about. And then the second thing is, I would say for the postmenopausal patients, what we really just want to make sure is that we're not triggering inflammatory activity in some way by exposing them to higher doses of hormones than sort of they're currently exposed to. So what we do see in a lot of autoimmune conditions is big shifts in hormones, and certainly it's more related to pregnancy levels. So marked shifts can be associated with actually sort of, worsening of inflammatory activity. And so I think that's something that I always just kind of keep in the back of my head had, if we're to sort of give different types of exogenous hormones to patients in the postmenopausal period, we just want to make sure that we're not worsening anything. So I think those are the two pieces that I'm just not sure about when we talk about inflammatory activity. I think that what we're really hoping for is to see we have such good anti-inflammatory medications for MS, we can really control the inflammation that we see. We're really hoping for ways of preventing neurodegeneration. So I would say that that is the mechanism that we'd really like to be able to sort of drill down on the most effectively.
Thank you. And Professor MacGregor, many patients have headache but not migraine. And do we know about oral contraceptives and their efficacy for headache generally? Can we extrapolate from the migraine story to headaches?
Well, in actual fact, more of the work has been done on headache rather than on migraine, and what that, with respect to combined hormonal contraceptives, and that is really just been looking at the effect of the hormone-free interval on increase in burden of headache. That if you then remove the hormone-free interval, which would equivalate to removing an estrogen withdrawal trigger, which is likely to be involved in headache as well as migraine, then yes, continuous combined hormonal contraception can be effective in that population, as well as easing all the other burden of symptoms associated with that hormone-free interval anyway.
Thank you. And Dr. Bove, are there general practices for pregnancy prevention in women with MS in light of estrogen and progestin effects generally on the condition?
Yeah, so historically, women with MS were advised not to become pregnant because of the risk of postpartum relapses, as well as sort of, oh, could you take care of a child if you had some disability? And what's really changed in the last 20 years or so is that we've learned that we can actually really manage the relapses before and after pregnancy. During pregnancy, patients feel quite well. And so we've really moved towards a phase towards a phase of sort of active engagement, active management of disease activity and supporting patients' fertility goals. That said, for people who do not want to have children or who don't plan to have them in the next few years, we do like the long-acting reversible contraceptives, the IUDs and such, because they do take the behavioral components out of contraception, and they do help patients sort of minimize sort of the different medications that they have to take and sort of manage on a day-to-day basis. And so we say, if you're certain that you don't want children the next few years, IUDs are great. And if not, let's plan your pregnancy carefully. Let's not have it be an accident. So those are our general practices. In terms of oral contraceptives, there's, I think we're really shifting towards just whatever would be generally indicated or contraindicated. It follows suite and multiple sclerosis. There aren't really many MS specific reasons to take or avoid an oral contraceptive. And so we do have a few observational studies that suggest that the continuous combined oral contraceptives can also help with sort of symptom stabilization in MS, as well as was presented for migraines, but the data are a lot, they're a little bit more patchy.
Thank you very much. Professor MacGregor, there's a lot of questions about progesterone and some clinical experience that there may be a subset of patients who respond well in terms of migraine to progesterone. Do you feel that there's any role for micronized progesterone or Depo-Provera, for example, in headache management?
Well, certainly, with Depo-Provera, that can be very effective at switching off, putting the ovaries to sleep in that sense, but you need to then add back the estrogen. With body identical progesterone, that is very likely to have more benefits to women with migraine than just using progestogens for endometrial protection. The benefits particularly being because it attenuates the effects of estrogen on the brain, whereas estrogen excites the brain, progesterone acts on GABA and tends to calm the brain if it's taken by mouth. So there may well be some benefits on migraine, but we really don't have the data. Nobody's really looked specifically at the combined HRT. The only work that I'm aware of that has looked at progesterone and migraine is a work by Geraldine Pryor, who's looked at just progesterone on its own in the absence of estrogen for management of menopause symptoms, including migraine.
Thank you. Dr. Bove, there's some evidence perhaps that testosterone promotes myelin repair in the central nervous system. Is there any clinical data or animal models to support the use of testosterone, or even in your clinical practice?
Yeah, that's a really, it's a great question. And it's a hard question. I think it's the same difficulty, as I outlined for estrogens. It's even harder to understand what the role of testosterone in humans, in human females and males with MS, just because of the burden, the barriers to doing the research are many. We have to overcome safety barriers to do sort of hurdles in people's minds about safety to get funding to be able to do the interventional work. And we've tried a couple times and not gotten it. And then in observational studies, the numbers are even patchier for testosterone. And so I would say, well, there's certainly hope and hypotheses that testosterone could help with sort of a lot of different symptoms, actually, potentially energy, fatigue, cognition, strength, etc., as well as potentially promote mechanisms of repair. We just don't have the data.
Thank you. Professor MacGregor, there's a question about different phenotypes of migraine presentation and a question about whether all variants may increase in the perimenopause, like vestibular migraine, ocular migraine. And then an interesting question of whether maybe some of the dizzy symptoms that women are reporting in the perimenopause might actually be new migraine. Can you comment on that?
Absolutely, I can see Dr. Bove shaking her head as well, or nodding her head rather in agreement, because I think, again, this is what you will probably be aware of is this lack of interface of research of neurology, neurological conditions, and menopause. And because we are from different specialties, I think that's one of the reasons why these things don't get properly researched. And we desperately need money, funding for neurological conditions during menopause. But yes, going back to particularly with things like what gets labeled vestibular migraine, we see it as a menopause symptom. This increase of dizziness, these increase in vestibular symptoms, when they occur in patients who have a past history of migraine, they're often labeled as vestibular migraine. But we really haven't properly looked into it. We don't know how HRT benefits or might adversely affect these particular vestibular symptoms that are occurring. With respect to ocular migraine, that's probably what we would term migraine aura. That's zigzaggy lines moving across your field of vision that we know that are associated with high levels of estrogen as one particular mechanism, but there are other mechanisms as well, because they do tend to be relatively more prevalent in postmenopausal compared to premenopausal women. But aura is the bit of migraine that we know least about.
Thank you. Dr. Bove, MS is one of many autoimmune conditions that have a higher prevalence in women than men. We have other conditions such as lupus, certain forms of thyroiditis. The lessons that you're learning from MS, do those generalize to those other autoimmune conditions?
It's a great question. I think ideally they will, as we dig deeper into sort of specific immune mechanisms, for instance. So what happens to B cell function or, T cell function. And, there's a lot of data in in sort of perhaps healthy populations or animal models, digging deeper into the clinical populations to understand what might transfer across the diseases. I would say the biggest thing that I've learned from the other autoimmune conditions and the research on menopause is really distinguishing the effects on the immune function, immune attacks, flares, from the effects on sort of the underlying organs and sort of, body. So distinguishing, again, sort of attacks from sort of like joint, right? Sort of joint integrity, joint degeneration over time, things like that. I think it's really important to parse them out for each of these autoimmune conditions, because when you ask patients, it may all be a bit jumbled for patients, and really trying to tease out what do we understand, evaluate, and treat, chasing the immune attacks versus how do we promote sort of resilience of the underlying organs or systems. I think that's a concept that I've really gotten from those other autoimmune conditions. I think each autoimmune condition is really trying to sort out what exactly happens during menopause and the postmenopausal period. And so there have been heterogeneous reports about what happens to the flares and what happens to overall sort of burden of disease. And I would say sort of the data are a little bit further advanced in these other conditions than in MS. They certainly started 5 or 10 years earlier than we did. But I think that's where I would stop, not being one of those rheumatologists.
So much more we need to know, isn't there, on sex and gender in menopause and women who experience these conditions, and the lack of representation, as you pointed out, in midlife women in these clinical trials. A great challenge. Okay, final set of questions. Professor MacGregor, there have been some questions about transdermal estradiol and its potential use cyclically in the perimenopause to control menstrual migraine and that withdrawal. Do you have any comments on that as a possible intervention?
Absolutely. We did the trial back in, published, if you want to look up the paper, it was published in, I think it was in Neurology, I think it was 2006 that we published, where we were looking at that exact same strategy of perhaps bridging that perimenstrual drop in estrogen by supplementing estrogen at that time. Taking it up to mid-luteal phase levels, and then allowing it to drop in the early follicular phase at the time that we would expect endogenous estrogen levels to have begun to rise, and thus protect against migraine. So we did find, as previous researchers have found, that during the estrogen supplement phase, there was a reduction in the expected migraine. The problem is that as soon as the estrogen levels dropped, it triggered estrogen withdrawal migraine. So estrogen withdrawal migraine can be independent from menstruation, and that was also the marker to us that progesterone was not involved as a trigger, because this was independent of the drop in progesterone as well. So that was something that previous researchers had not looked at. They hadn't looked at what happens to migraine at the end of supplementing. And it wasn't a strategy that I use now, both for the reason that it didn't seem to be effective, it just delayed it, and also for the reason that during perimenopause, it is incredibly difficult to time treatments that start before the menstrual period because of increasing menstrual irregularity. That's why the continuous combined contraceptives become by far the better strategy.
Thank you so much. So not helpful for the patient, but helpful to reaffirm the mechanism of action of migraine. Okay, great. And then finally, Dr. Bove, I think a lot of people think about estrogen as, the key factor in triggering worsening symptoms across a variety of diseases, but we do know that factors such as vasomotor symptoms, as you mentioned, but also sleep disturbance increases, tremendously in the perimenopause. Many women experience months and even years of sleep disturbance. And I wondered if you had a sense of the impact of the menopause symptoms as opposed to the hormonal changes on MS or MS symptoms, and whether interventions for the symptoms like sleep interventions, ICBT, et cetera, may be helpful.
Yeah. Yeah, I mean, I'm so glad you mentioned the sleep, because it's one of the things that a lot of neurologists actually miss in their individual diseases, and that it's so critical. Of course, there's the increase in sleep apnea postmenopausally. There's the sort of the awakenings from the vasomotor symptoms. There's also in our neurological populations, the bladder function is substantial. So we have patients who have awakenings many times a night for sort of either bladder dysfunction or spasticity. And so sleep is interrupted for all of these reasons. Yet certainly the vasomotor symptoms, certainly sort of underlying changes in sleep regulation, as well as increases in OSA and as well as increases in neurological symptoms. And so it really is another, you know, I started a collaboration with a sleep researcher expert to kind of help us disentangle some of this, because I think it's a very big problem in the neurological populations as well as in the general population during this transition. And the approaches are going to be really multifactorial, yeah, multi-pronged.
Thank you. All right. Many thanks to Professor MacGregor and Dr. Bove for their excellent presentations and all the insights that we gained from this topic. Thanks to all of you. We had a great turnout today for this session. Thanks for your questions. Thank you for your support of the International Menopause Society. I'd like to remind our audience that the 19th World Congress on the Menopause will be in Melbourne, Australia, the 19th to 22nd of October of 2024. We would love to see you all there, where you can learn about topics such as these. Thank you very much. Thank you again to Bessons and to all of you. And we wish you a very good day.